My name is Brian Holcomb, and I'm excited to announce the introduction of CYP3A4 and CYP3A5 to the YouScript panel. Our vision at Genelex is to improve the quality of life and save healthcare resources by providing the tools essential for personalized prescribing, wherever medication decisions are made. To be considered a part of our panel, a genetic test must meet these three qualities. First, it must be pharmacokinetic focused. Our current tests are a set of biomarkers essential for predicting cumulative drug response. Second, it must be data-driven. An impact on drug metabolism along with a measurable increase or decreased enzyme expression and activity is used by our P&T committee to confirm the clinical utility of a test. And finally, it must be population-centric. We require a greater than 5% frequency in the population to be considered a part of the testing panel. By adding CYP3A4 and 5 to our panel, it allows us to personalize the pharmacokinetic predictions for up to 78% of all hepatically cleared drugs. The other 22% that we don't test for are handled by our software, which stores over 300 physiologic drug pathways. Statins, combined oral contraceptives, cyclosporin and tacrolimus, benzodiazepines and fluticasone are just some of the many drugs metabolized by these pathways. CYP3A activity has displayed up to 100-fold variation between individuals, and 85% of this variability has been attributed to genetic factors. However, the CYP3A4 polymorphisms discovered prior to 2011 had either very low frequencies or did not correlate to decreased mRNA expression and enzyme activity. Then the STAR22 allele was discovered in 2011. In addition to having confirmed effects on drug metabolism, the STAR22 allele carriers displayed a 60% decrease in mRNA levels and enzyme activity compared to STAR1 homozygotes. CYP3A4 and 3A5 share 85% homology and have significant substrate overlap, which is why it is important to test both of these enzymes. Up to 5% of patients of European descent will be CYP3A4 intermediate metabolizers, and for CYP3A5, 50 to 73% of those from African descent will be rapid metabolizers, while 7% of Europeans will be rapid metabolizers. Okay, so how do we understand these new phenotypes? Our traditional way of thinking about them no longer applies. For CYP3A4, a normal metabolizer has two active alleles. An intermediate metabolizer has one normal and one reduced functioning allele, or two reduced functioning alleles. For CYP3A5, a normal metabolizer has no active alleles. A rapid metabolizer has one active allele and one inactive allele, while an ultra-rapid metabolizer has two fully active alleles. This is quite different than what we are used to. And rather than using the lanes or highway analogy for drug metabolism, a way to think about these new phenotypes is to use the sink and drain analogy. Think of the sink as your patient, and the water flowing into the sink the drugs you are prescribing. For the water to drain out of the sink, it must travel through one of the drains. A poor metabolizer on the far left has slower flow of water out of the sink, or decreased drug cleared from the patient. An ultra-rapid metabolizer on the far right will have increased water flowing out of the drain, and increased drug clearance from the patient. On the right, you see the new phenotypes that are being added to the YouScript panel. With CYP3A4, we have a normal and an intermediate metabolizer. With CYP3A5, we have a normal, rapid, and ultra-rapid metabolizer phenotype. Clinically, we think about these new phenotypes the same way we always have. Poor metabolizers will have increased exposure of the drug and increased risk for toxicity, while ultra-rapid metabolizers will have decreased exposure of the drug and increased risk for therapeutic failure. I'd like to personally thank you for watching this webinar. And as always, if you have questions or concerns, call us at 1-877-431-4362 or email at info@genelex.com.